Okay. Last time we had read about the basics of FFA. So today we will be going over the main examples in some of the main diseases of FFA. Okay, this is how we interpret. We study the color photographs and or we do the indirect fundus examination. Then we take a rate-free photographs of the eye. We have to do the fluorescent angiography, and we note what has to be there on the photographs is time, phase, and location of all the photographs which we take FFA. And in the photograph, what we have to look for? We have to look for hyperfluorescence or hypofluorescence, and the frame changes in size and intensity. Whatever changes are there in the size of that hyperfluorescence or intensity of that hyperfluorescence, we have to see. And there is any timing or delay in the fluorescence in the eye, that we have to note. So coming to the next thing, what are the causes of hyperfluorescence? What are the causes of hyperfluorescence? Causes of hyperfluorescence. The first cause can be a RPE window defect. Whenever there is a RPE defect, the fluorescence from the choroid will appear more in all the phases of the fluorescent angiography. And what these RPE changes can be, it can be atrophy of the RPE, it can be age-related macular degeneration, it can be any retinochoroidal dystrophy, or it can be a choroidal rupture post-trauma. The thing is, the hyperfluorescence increase along the initial phases of the fluorescent angiography and decrease with the phases, because this hyperfluorescence is from the choroid and it is visible in the initial phases as hyperfluorescent and later on as hyperfluorescence, and later on as the choroidal flush decreases, this hyperfluorescence also decreases. Next is pooling of the dye. How does pooling of the dye occur? For any pooling to occur, there has to be some space. So, and there has to be some leak. So, where is the leak? Leak is in the RPE Brooks membrane barrier. So the second barrier we have, that is the RPE Brooks barrier, that breaks and it leads to pooling of the fluorescing dye in the retina. Example can be pigment epithelial detachment, that is the PED or the RPE detachment, and other example can be CSR, and another example can be serous detachment of the retina, and the most common example is CME, that is the pooling of the dye. In this pooling of the dye, what happens? There is slow increase hyperfluorescence throughout FFA angiography phases, and even after that in the late phase, that pooling remains. The third cause of hyperfluorescence is leakage of the dye. How does leakage of the dye occur? Leakage of the dye means continuous leak of the fluid. Pooling means once the dye has come to the retina, it stays in that space for a long time. Leakage means continuity in the increase in size of the dye which is coming to the retina. So leakage can happen whenever there is extravasation. Whenever there is extravasation because of some retinal vessel abnormality, that is, the vessels will keep on leaking in all the phases of the angiography, and that's why there is early intensity increase in the leakage throughout the FFA. So, what are the examples of the leakage of the dye? The example can be microaneurysm, neovascularization, intraretinal microaneurysms, that is the IRMAs, and microvascular abnormalities, intraretinal microvascular abnormalities, that is the IRMA, and the wet AMD, that is the CNVM, can cause leakage of the dye. And there is an early intense leakage which increases throughout the FFA in these examples. What is the fourth reason of the hyperfluorescence on the FFA? That is the prolonged dye retention. Whenever the dye is coming, it is slightly leaking, and but that dye that those tissues capture that dye and get stained and don't let the dye go off for a long time. That is called staining. The example of the staining are drusen. Drusen can be optic nerve head drusen. It can be a retinal drusen as shown in this example. It can and even the optic nerve head rim, even the optic nerve head rim, scleral rim and the tissues also have staining. The sclera has staining and the vessel walls have the staining, as we can see the vessel's wall for a long time. As we can see the Next, we come to the causes of hypofluorescence. What are the causes of hypofluorescence? The first is blocked retinal or choroidal fluorescence. When the fluorescent dye, which is in the retinal and the choroidal vasculature, but we can't capture it in the camera because there is some blockage in the outcoming pathway. What are the examples of these blockages? Any hemorrhages. These hemorrhages can be pre-retinal, these can be intraretinal. Whenever there is a pre-retinal hemorrhage, we can't even see the retinal vasculature. Whenever there is an intraretinal hemorrhage, we can't see the choroidal vasculature, and in the choroidal phase, there will be a hypo. The other example is exudates. Exudates also cause blocked fluorescence. The cotton wool spots, that is the infarcted areas of the retina, when they swell up, they don't let the fluorescence pass through. And any glial tissue in the retina. These are the examples of hypofluorescence on FFA. As you can see here, this is the AV phase of the angiogram, and there is still hypofluorescence in the center. The second example of hypofluorescence is a vascular filling defect, and this vascular filling defect can be because of vascular occlusion, emboli, arteriosclerosis, or vascular non-perfusion. Okay, the first example is of vascular occlusion. In this, we see an area of hypofluorescence, and most probably it's due to the vascular occlusion almost here, either due to emboli or arteriosclerosis, and leading to the non-perfusion of all this area in the retina. The second example is of the vasculitis causing non-perfusion of this area. The third reason which can cause hypofluorescence is the loss of vascular tissue, as in this example, in cases of very high myopia or choroideremia. We have to differentiate between two entities, between autofluorescence and the pseudofluorescence. Autofluorescence example is that these structures in the retina don't need fluorescence to give out fluorescence, don't need a fluorescent dye to take, don't need to take the fluorescent dye to emit fluorescence. That's why they will be fluorescent in all the phases of the angiogram, be it very early phase, even before doing fluorescent, even before starting the procedure. These structures will appear fluorescent. Examples are optic nerve head drusen and myelinated nerve fiber. What is pseudofluorescence? Pseudofluorescence means these structures are not autofluorescent. These will not appear fully fluorescent in all the phases. There will be a transit time of 10 to 20 seconds. That is the first initial phase. They will appear slightly fluorescent, and recirculation phase, these will become less in intensity. That is the pseudofluorescence. A note about oral fluorography. It is not as good as intravenous fluorescein angiography. It is useful when the late leakage, only the late phase of the fluorescein angiography is of interest. It is safer, no doubt, and it is safer in children or the cardiovascular compromised patients. In this, what is the thing? We require 8-hour fasting. The dose is 15 ml of 10% sodium fluoride, which is taken through the oral route. Dentures have to be removed if the patient is using dentures. The photo shoot has to start at 15 to 20, 30 minutes after the ingestion. We have to look for the first sign of fluorescence in the fundus. The thing is, we are making the patient wait more with the chin rested on the camera, and we are looking for the first sign of the fluorescence. We are taking so many photographs, and once that fluorescence comes into the retina, we have to take the photographs. That's why we mostly take phases whenever we mostly take photos whenever the late dye leakage is of interest, or we have to capture only the last phase of the angiography, that is, and the last phase in the oral fluorescein angiography starts approximately 1 hour after the ingestion. What are the factors affecting the visualization in the FFA? It can be the clarity of the media. That is, clarity of the media includes the clarity of the cornea, the clarity of the lens, and the clarity of the filters of the FFA. The second is how much the pupil is dilated. If the pupil is not that much dilated, fluorescein angiography photographs will not appear that clear. The third one is sodium fluorescence concentration, which is reaching the eye. If it's too much concentrated, the dye will leak out very fast and we will not be able to see the structures. That's why the dose of fluorescence we are using is important. The quality of the camera, the film, and the filters also play a role. The examiner skill, no doubt, has a very important role, and along with the patient's cooperation. So, for pre-counseling, if the patient is a child, it should be accompanied by an adult attendee. Even an adult patient should be accompanied by a bystander. We have to explain and obtain a verbal and a written consent from the patient. The before doing fluorescein angiography, as nausea and vomiting are the common side effects, we have to take 3 hours fasting, and after that we have to do the this procedure. The test dose has to be given, and after giving the test dose, we have to wait for around half an hour to check the fluorescein effect. We have to put a tiny cannula. After putting the tiny cannula, we have to see the dilatation of the pupil, and we have to wait the patient, and we have to make the patient know that the patient will have to wait for more than 1 hour for the diagnostic procedure to actually finish off. And if the patient is and if we should tell the patient that if they feel any discomfort or shortness of breath after the test dose, they have to tell us. After the procedure, what is the thing? Usual diet can be taken. If any allergic reaction, skin rash, or itchiness is there, we have to inform the doctor at once, and the doctor can accordingly prescribe the medicines. We have to tell the patient to avoid driving at least for 24 to 36 hours as the pupil, as we have dilated the pupils, and there will be a yellow skin, and the urine might be urine for the next 36 hours. Some emergency medicines which have to be there in the crash cart table are emergency. Main thing is oxygen cylinder or the ambu bag has to be there in case of anaphylaxis, evil for allergy, Decadron injection, any asthma problem, Derifilin has to be there. Adrenaline is given whenever there is low BP and heart rate because of the low anaphylaxis. Atropine in case of very acute emergency when adrenaline is not working. Lysis injection if we suspect pulmonary edema, and dextrose if the patient is especially diabetic and during the diagnostic procedure they develop hypoglycemia. And other things we have to keep the fluids with us ready, and syringes and emetic tablet for nausea and vomiting. So next we will go to the examples of fluorescein angiography. This is an example of the CRVO, central retinal vein occlusion fluorescein angiography, and this is the montage picture of the FFA done. What we see here is the that this photo is taken in the late AV phase. As we can see, the vessels, all the vessels are filled with the dye, and the arteries are slowly getting empty. So this is the late AV phase of the angiography, and this shows disc edema at the center because of this leakage. And we see a lot of leakage, hyperfluorescence leakage all around because of the many microaneurysms And at the same time, with the hyperfluorescence, we see areas of hypofluorescence because of the pre-retinal hemorrhages. So this is acute phase of the CRVO, what we are seeing, and this angiography is around late AV phase angiography. This is the example of diabetic retinopathy. We can see the laser marks. We can see the laser marks. The laser marks are hyperfluorescent in the center with a hyperfluorescent rim around them. With the hyperfluorescent rim around them, indicating very mild staining of the borders. The fluorescein angiograph is in AV phase. In AV phase, and we can see numerous microaneurysms at the borders where the laser and the normal tissue is there. We can see numerous microaneurysms coming up, and we can actually note some area of capillary non-perfusion here. Some area of capillary non-perfusion where there is less laser, and this may need add PRP, and this might need add PRP, and we can notice a small hyperfluorescent, this might be a hyperfluorescent thing, this might be a leakage point, and we have to see in the next phases whether this is increasing in size or it is remaining the same, or it can be some drusen, retinal drusen, and we have to see the later phase of the same patient whether this is a leakage pointing to CME or this is a retinal drusen. Next example we come is ultra wide field fluorescein angiography. This ultra wide field fluorescein angiography is taken by a camera, is taken by a fundus camera, which can take the images up to 200 degrees, which can take images up to 200 degrees. In what is the use of ultra wide field fluorescein angiography? We don't have to do the montage. Second thing is the whole photograph, the whole fluorescein angiography of the whole fundus is visible at the same time, and we can see the periphery of the retina also clearly using this ultra wide field fluorescein angiography. In this example, the temporal periphery is totally non-perfused, and we can see the vessels joining each other rather than going into this peripheral tissue. So they are forming the loops at the junction of the non-vascularized tissue and the vascularized tissue, and this can be anything like FEVR, like ROP. This can be anything. So this is the example of AMD with the window defect. Here what we see in the OCT of this AMD lesion, what we can see is there is a retinal thinning. There is a retinal thinning along with RPE Brooks membrane defect, and we can see more light passing beyond the RPE because of this window defect in the RPE. What we see in the fluorescein angiography is the initial hyperfluorescence. This is the early AV. This is the early AV phase, and we see the initial hyperfluorescence. This is the late phase of the angiography, and we see this hyperfluorescence has increased with the late phase. And with the more later phase, we see this hyperfluorescence has increased more in intensity. So this is the window defect in which the choroid is getting filled with the hyperfluorescence, and in this window and this choroidal hyperfluorescence keeps on increasing with time, but the size of the lesion does not increase. So this is the example of hyperfluorescent increasing intensity with time with no increase in size because of the RPE defect, that is the window defect. The second example of window defect, this is the late AV phase, and in this, not late AV phase, this is the late phase of the angiography in which we see the angioid streaks, that is the RP defects in the RP defects in the choroidal, in the RP Brooks membrane. We see the angioid streaks uh, coming out, and we see them as hyperfluorescent streaks in the late phase of the angiography. This is the example of chronic CSR. This is the example of the chronic CSR in which we have done the fluorescein angiography, and this is the late phase. As how it is the late phase of the angiography, as all the vessels are already stained, along with there is a choroidal mild hyperfluorescence we see all over, and there is a scleral rim, and scleral rim has also stained. So this is the late phase of the fluorescein angiography, and what we see here, some area of hyperfluorescence indicating RPE RPE defect along with the borders with hyperfluorescence. What we see here is a leaking aneurysm, not aneurysm, leaking point at the Brooks membrane here, along with hyperfluorescence in the nearby area. And what we see otherwise is a dye, and this dye is gravitating down, and this dye is gravitating down. So this is these two are the PEDs, and this is the chronic CSR. So other example of wing door defect is the stage 4 macular hole. Stage 4 macular hole is a large macular hole, and in this stage 4 macular hole, what we see, this is the angiography. In what phase? This is the early AV phase. Why early AV phase? Because arteries are filled and the venules have started filling, and the venules have started filling in the laminar flow. So this is the early to mid AV phase, early to mid AV phase, and in this early to mid AV phase we see the choroidal hyperfluorescence in the macular area, which is not increasing in size but increasing in intensity in the center. So this is the stage 4 macular hole fluorescein angiography. The next example of wing door defect is placoid epithelopathy. The example is GHPC, generalized helicoid placoid choroidopathy. In this placoid epithelopathy, what happens is that the outer retina and the inner choroid gets damaged. The outer retina and the inner damage gets damaged. So we can see directly the choroidal vessels. So we can directly see the choroidal vessels. The larger choroidal vessels we can directly see. These are the larger choroidal vessels. In between the retinal vessel, this is a retinal vessel, this is a retinal vessel which is going, and in between these are the choroidal vessel hyperfluorescence. But there are no choriocapillaries because the inner choroid is already damaged in GHPC. So we see a window defect. We don't see a choroidal hyperfluorescence in this area. Choroidal hyperfluorescence, which is due to choroidal capillaries in this area, but we see the larger choroidal vessels. And at the same time, what is the phase of this angiography? This is the AV phase of this angiography. As we can see, arteries and veins both are filled, along with a choroidal flush in the periphery, but not in the center where the lesion is there. The next example of window defect is the traumatic retinopathy. What happens in traumatic retinopathy? The RP defect can happen. When the RP defect can happen, we can see many hypo along with hyperfluorescent dots. Hypo with hyperfluorescent dots, which show us the damage which has happened in the RPE. What is a choroidal? The next example post trauma is a choroidal rupture. The thing is, the choroidal rupture, it always moves. Its margin will be parallel to the margin of the disc. This choroidal ruptures direction will be around parallel to the margin of the disc when it happens. In this choroidal rupture also there is a window defect hyperfluorescence we see, and we see the hypofluorescence due to the hemorrhage associated with the choroidal rupture. This is the other example of the choroidal rupture. This is the example in which phase of the angiography this is taken, AV phase. This is the other example in the in the early AV phase. Arteries are filled, laminar flow in the veins in the early AV phase. We can see the choroidal fluorescence, hyperfluorescence, and along with that there is a hypofluorescence indicating some hemorrhage. And along with this yellow arrow, what does it point to? Some membrane occurring in this choroidal rupture, which can be leaking, and this is in the late phases this might leak out. So next thing of hyperfluorescence is leakage. Examples are CSR. In CSR, in CSR, one minute. Leakage example is CSR. In CSR, in the AV phase, we see a point-like thing which is leaking, and with the more phases, this will increase in intensity and the size. What we typically call as ink blot sign. Okay, example. The next example is this. This is also an ink blot sign, in which the leakage is increasing with time. With the various phases of angiography. This is the umbrella sign, in which the leakage point because of the convection current of the fluid. This is the CSR boundary. Because of the convection fluid of the in the retina, this will appear as an umbrella coming up. So this is the umbrella sign. This is the example of the chronic CSR, in which there is a RP defect and slight window defect is there, along with many leakage points we can see. And this is the example of the OCT of this lesion, in which we can see the RP defect and some leakage happening, actually getting captured in the OCT itself. So other example of leakage is CNVM. CNVM can be occult. CNVM can be classic. So this is an example of classic CNVM, in which in the late phase we can see the leakage, hyperfluorescent leakage all over, along with mild hypofluorescent because of the hemorrhages. But along with this classic CNVM, there is an occult CNVM here, and occult CNVM also has many dots like leakage, but not frank leakage as a classic CNVM. The occult CNVM will have hypofluorescent appearance along with hyperfluorescent dot-like structures. This is an example of CNBM, that is RAP. This is the lesion of RAP. We can see some dot hyperfluorescent dot happening in the retinal vasculature here almost. And the same dot, if we capture on the OCT, we can see there is an anastomosis between the retinal vessel and some choroidal vessel here. So this is the example of RAP lesion. Vasculitis. Vasculitis causes leakage because in this there is the inflammation of the endothelial cells, and it will not be at one point, it will be at multiple points. There will be a leakage at multiple endothelial cells, causing the leakage which is increasing in size. And because of this leakage, there is a capillary non-perfusion area beyond these leakage spots. This is all the capillary non-perfusion area. So this is the classic example of angiography of the vasculitis. Whenever there is a leakage, if there is a SRF, there will be pooling also. And this pooling will appear as hyperfluorescence. And wherever the blood is not reaching, it will be hypofluorescent. So this is an example of retinal angioma. In which the retinal angioma in the periphery, in which the blood is leaking, in which there is a lot of leakage of the blood, and that's why dye is also leaking. And along with that leakage, there is a pooling also in some specific areas, and we can always laser these angiomas. The second example of pooling is pigment epithelial detachment. In pigment epithelial detachment, as these are the photographs of the PED, this example actually tells PED very classically. So this is the arterial phase of the angiography. In the arterial phase of the angiography, we can see hypofluorescence still in various areas, and we can see in the center some choroidal hyperfluorescence. And along with this, what we see is, with AV phase setting in, what we see, this choroidal hyperfluorescence increases, and there these lesions also increase in fluorescence. These three lesions, Y shape we can see there, Y shape we can see here, are increasing in fluorescence. And in the later phase, what we notice is that this, along with these three lesions, are increasing in hyperfluorescence, but they are not increasing in size. So this is called pooling. This is called pooling, and this is the late AV phase of the angiography. Late phase of the angiography. Still, it's hyperfluorescent area. So this is the pooling, and the pooling. This is the classic example of PED. The next example of pooling is angioma. Angioma in VHL. So in angioma, what phase of is this angiography? This is the late phase, very late phase of the angiography, in which already there have been many recirculation phases. We see some staining, and there is a pooling only in the angioma. The next example of pooling is CME. In CME, what happens in the late phases also? In the late phase of the angiography, we can see this typical cystoid macular edema having a leaf-like pattern, because of the Muller cell arrangement. Muller cell arrangement, what we call as a starry leaf-like pattern. So we can see this is the classic example of CME in the late phases of the angiography. This is also an example of CME having a petaloid pattern, same as this. Along with that, there is a disc edema. That is, the disc is also leaking, and this is the example of late phase of the angiography, as already there is a choroidal fresh arteries and veins are already stained. This is another example of CME in which there is a mild CME along with the staining of the disc scleral rim. There is no papilloedema in this case, only CME in this case, but here there is a disc edema also associated with CME. The next example of pooling is choroidal melanoma. This is also the late phase of the angiography, and this is some growth which has been observed in the angiography, and we see that here there is a leakage, many points leakage is there, and the fluid is getting collected at the periphery of that lesion. So this is the pooling happening in the choroidal melanoma in the late phases of the angiography. Staining. In staining, we know that many microaneurysms start leaking, but these microaneurysms, once they leak, they leave out stains in the late phases of the angiography, and that is what points us to the diabetic microangiopathy. The next example of staining is venous branch occlusion. Venous branch occlusion. So in this, what happens? There is a vein occlusion over here where there is a yellow spot. That's why there is a lot of leakage here. Lot of leakage happening here, and there is no blood vessel is not reaching here. That's why there is hypofluorescence in this area. There is a leakage happening here, and this is the vein going, this is the artery going, and what we see in the late phases of the angiography is that these blood vessels don't lose their fluorescein easily because of the venous blockage happening here. So once the venous blockage is here, these will get stained more. So this is the example of staining. These blue arrows are the example of staining, and it can happen with anything like new vessels, AV shunts, because the veins can't leak the vessels so fast in the late phase. That's why this staining is happening there. So next we will come to hypofluorescence. The reason for hypofluorescence can be hemorrhages, which can be pre-retinal, like here. There is a pre-retinal hemorrhage which is blocking the view of all, even the retinal vessels. So this is the example of BRVO, because this vein is getting blocked, and that's why there is a hemorrhage over here. And there is a hypofluorescence in this area because of this vein getting occluded, branch vein occlusion. This is the vitreous hemorrhage. Because of the vitreous hemorrhage, we don't see even the retinal vessels or the choroidal vessels, and there is a hypofluorescence. And this is the what phase of the angiography? This is the early AV phase of the angiography, artery is filled fully and the vein is having a laminar flow. This is BRVO example. This is the characteristic late AV phase. Late AV phase. If there is a deep hemorrhage, we can see the retinal vessel going over it. This is the retinal blood vessel going over the hypofluorescent area, and there we see some leakage happening in this area. So this is the example of CNVM with hemorrhage. Why CNVM? Because there is a leakage in that membrane, some area, along with the all the retinal blood vessels. We can see they are going over this area of hypofluorescence. So this is a deep hemorrhage, possibly post wet AMD. Next is pigment hyperplasia. Pigment hyperplasia will happen. There will be lot of RPE cells collected there, and these RPE cells will be so thick that the down choroidal fluorescence will not appear. The pigment hyperplasia patients, this hypofluorescence will not decrease or increase in size. Its size will remain constant, and we can see the blood vessel going over that lesion. So this is the example of pigment hyperplasia. Next is the example of hard exudates. How the hard exudates look in the early stage of the choroidal phase of the angiography. Artery and veins still are not filled, but there is a fluorescence, but there is an autofluorescence of the hard exudates we see here. And when the in the late phases of the angiography, this hyperfluorescent hard exudates will appear as hypofluorescent. How this happens is because the fluorescence of the side area increases too much, that then they will start appearing hypofluorescent. Okay, so the hard exudates are actually autofluorescent, but later on they appear in fluorescein angiography. They can appear hypofluorescent in the late phases of the fluorescein angiography because they are not taking up any dye, and the remaining area has become more hypofluorescent compared to the hard exudates initially. The next example is of branch retinal artery occlusion. So we can see the retinal artery, and here there is an occlusion, and here we see the tram track, classic sign of tram track appearance. uh, and in this we can see where the occlusion is there is a leakage from the artery. There is a leakage happening from the artery. What phase is this? This is the late phase of the angiography, as all the choroidal vasculature is already filled with angiography. The optic disc scleral rim is already stained, and we can see the leakage also. So this is the late phase of the angiography. BVO. In branch vein occlusion, what we have to note. So first is, what is this phase of the angiography? This phase is arteries and veins both had been filled, and now there is a staining of the vessels. Along with that, we see that the vessel along here has not get emptied from the blood. So there will be some occlusion which is not letting this dye go away and recirculate. So there is a vein occlusion because arteries are already getting empty, veins are still not empty, and because of this occlusion, other thing we see is that there is lot of hypofluorescence here. There is lot of hypofluorescence here, and this hypofluorescence here is due to mostly ischemia, and over here it is like there might be some hemorrhages. There are many microaneurysms like structures happening. So this is a classic example of BVO, classic example of supratemporal BVO along with some macular ischemia. The next is Moswich disease. Moswich disease is peripapillary hypofluorescent area. In this disease, this is a kind of a syndrome in which there is hypofluorescent area around the disc area in the choroid. As in the choroid, some choriocapillaries will be lost, and this will appear as hypofluorescent area around the disc. These are the examples. This is an example drepanocytosis, that is the RBC red blood cell problem, in which there will be capillary non-perfusion in many choroidal areas, and there will be no choroidal flush, and because of this there will be like very small emboli, which will cause occlusion of very small arterioles, and that's why this capillary non-perfusion area along with leakage in many areas, that is the microaneurysms at the junction of non-perfusion and the perfusion area. What other thing we see in diabetic retinopathy is the filling defects. Filling defects. So we can see one microaneurysm here which is leaking. The second thing is we can see our two vessels which are getting connected like a shunt. We can see a shunt like thing. And the third thing is we can see that these vessels are not still there is a lot of capillary non-perfusion area here, which is because this blood vessel has not filled still fully and not causing fluorescein to fill in the adjacent area. So this is the capillary non-perfusion area. So this we have discussed about hyperfluorescence and the hypofluorescence. So next, what we should see also is whenever we put a dye, we normally tell that it takes 10 to 12 seconds to reach the eye. That is the arm to eye time. But in some cases, it reaches the eye very fast. What we call it as accelerated filling, and this accelerated filling can be because of congenital AV anastomosis or secondary to some partial venous abnormalities. There can be a retinal angioma, there can be a chorioretinal anastomosis, there can be choroidal hemangioma, and in some cases, the melanoma of the choroid can also cause accelerated filling of the eye. The next thing is delayed filling of the dye. This delayed filling, what is the definition of the delayed filling? That the filling affected eye, that is the affected eye, the filling will occur 8 to 10 seconds later than on the non-affected eye. And for the late venous phase, this difference will become more than 20 seconds. Then we label it as delayed filling, and this delayed filling occurs in general circulatory disorders such as myocardial diseases, any pulmonary congestion, any altered viscosity of the blood, any carotid stenosis. In the retina, this delayed filling happens whenever there is a venous occlusion like central vein or the branch vein occlusion. In the choroid, this delayed filling happens whenever there is a physiological filling delay of the choriocapillaries because of the mosaic aspect, that is the physiological filling delay. Because in the choroid, we have a structure of the choriocapillaries. The choriocapillaries fill in pyramidal form, in a pyramidal form. So there is always a physiological delay of around 1 second of the choriocapillaries because of the mosaic aspect of these pyramids. And delayed filling occurs in the choroid if there is an obstruction of the posterior ciliary vessels. In the optic nerve, when in the optic nerve problems, when does delayed filling happen? Whenever there is a hypoperfusion of the vascular optic disc, and in this what happens, there is a late peripapillary hyperfluorescence or there is a coloboma of the optic nerve, delayed filling happens. So this is the looping of the vessel in the diabetic retinopathy along with the new vessels. New vessels are happening on the both sides of the vessel, and this is also the looping classic example. This is the leaking micro to macro aneurysm, and these are the leakage points. These are the leakage points along with capillary non-perfusion area. Macular ischemia. Normally the hypofluorescent area at the macula is around 2 disc diameter in size. If it is more than that, we label it as macular ischemia. And here in this example, we can see a leakage at many points along with the along with hypoperfusion area, that is a macular ischemia happening in too large an area. So this is a classic example of macular ischemia. In classic CNVM, we see hyperfluorescent in the early to late phase of the angiography, but in occult CNVM, we don't see a classic hyperfluorescence. We see hypofluorescent area. We see hypofluorescent area with many uh, block like leakage spots, leakage hyperfluorescent spots. So this but this is all under the retina, as we can see the blood vessels going over this lesion. So this is a classic example of occult CNVM here. And this the leaking is an example of classic CNVM along with the occult CNVM. So this is an example of FFA and ICGA. In FFA, the occult CNVM will appear as hyperfluoro will appear as this is the both classic and occult CNVM. So here what we see is hyperfluorescent lesion along with many blocked hemorrhages in this area. When we do the ICGA, we capture this occult CNVM which was hiding in classic CNVM, because we are capturing this ICGA at a different depth. This is an example of a polypoidal choroidal vasculature having a polyp-like lesion. Along with this polyp-like lesion, we see a leakage around it. And there are many small RP defects which are appearing hyperfluorescent dot-like here. There can be a pattern dystrophy in which there is a these Y-shaped hypofluorescent lesions because of the RP hyperplasia. Along with the wing-door defect, there is a hyperfluorescence also in this area. So this is an example of pattern dystrophy. This is how Stargardt's disease looks like in the fluorescein angiography. There is a black choroid, not hypofluorescent choroid. There is a hypofluorescent choroid. We also label it as silent choroid because the choriocapillaries don't get filled and we can't see the choroidal vasculature that much. Along with that, what we see is the leakage type thing at the macula. This is not actually leakage. This is actually the window defect at the macula, which is very hyperfluorescent, and we can see the choroidal flush fast in the macular area. What is bullseye maculopathy? In bullseye maculopathy, we see a choroidal flush in the center, choroidal hyperfluorescence in the center because of the window defect, because of the RPE damage. In CRO, what happens? The blood is not reaching. Blood is not reaching the whole retina. There is a delayed filling. Along with what we see, the some arteries supplying the macular area have got filled in a retrograde fashion. So there can be some short posterior ciliary linked to this artery, and this is the classic angiography of CRO patients where vision is still good. So there can be some posterior ciliary artery which is supplying the macula, and in the same way there is a retrograde filling of the arteries. This is an example of BRAO in which there is a delayed filling in this quadrant. So this is a classic example of inferior BRAO. In chronic CSR, we will see a gravitating hyperfluorescent fluid collecting as pooling. In CSR in kidney patients, we will also see pooling in the subretinal area. When this CSR patient will have lock of SRF. So we will see pooling. In RP hypertrophy, we will see the hypofluorescent area. The retinal vessel is going over this area, and this hypofluorescent area is we can't see the choroidal flush. Whenever there is nevi, in nevi there will be a hypofluorescence. But in along with that hyperfluorescence, there will be some along with that hyperfluorescence, there will be some hyperfluorescent dots over this nevi, which will tell us about the orange spots over this nevi, which correspond to the orange spots over this nevi. They will be hyperfluorescent dots over the hypofluorescent lesion. So this is the nevi with bruisins. In multifocal choroiditis, what happens? There will be the different foci which will leak slightly. There will be different foci which will leak slightly and be hyperfluorescent. And there can be some lesions which are hypofluorescent in the center with hyperfluorescence at the borders, which show that the lesion is progressing. In ICGA, corresponding ICGA, these lesions will appear hypofluorescent. So in vasculitis, as we have already seen, there will be a leakage. And beyond that leakage point, there will be some non-hypoperfusion. What is this phase of the angiography? This phase of the angiography is early AV phase. Early AV phase, as the artery is getting leaked along with vessels still in the along with the vein which is still in the laminar phase. So this vasculitis is involving the arteries also. Frosted branch angiitis. In this, what we see is these arteries which are there. These arteries which are there have a lot of inflammation. This is a classic frosted branch angiitis, which can be seen in TB or sarcoidosis, and the veins are still in the laminar phase of filling. Next is retinitis pigmentosa. Why FFA is important in retinitis pigmentosa is in retinitis pigmentosa we can see so much RP atrophy, which is hypofluorescent dots all over. In at down area, this down area, we can see actually capillary non-perfusion, and we can see multiple telangiectatic vessels along with the aneurysms. So this shows the capillary non-perfusion, peripheral non-perfusion in the retinitis pigmentosa patients. In sarcoidosis with vitritis, we can see these vitritis lesions which appear as hyperfluorescent dots all over along with the disc edema. This is an example of FEVR. In this, there will be a capillary non-perfusion in the periphery, and we can see there is some leakage. Vessels are stopping here, and we can see there is some leakage at the border of the perfused, non-perfused retina. Coats disease, we see multiple telangiectatic vessels along with telangiectasias. And here there is a leakage along with some hypofluorescent, that is might be hemorrhage, and along with this we see in the center there is a leakage corresponding to the CME, cystoid macular edema, and this area is totally non-perfused area. So with this I end this talk.